Well, welcome everyone. Gosh, did somebody pay you to come in here? Or are you actually just here because you're interested? Extra credit. I knew there had to be some reason. People just don't show up to this kind of stuff for no reason. Well, we're going to talk a little bit about Alzheimer's disease and some other kinds of things that cause memory impairment. So to start off with, I guess I didn't have to worry about the font on this time, huh? Before I usually start doing any kind of a presentation, generally the audiences are smaller and it's a lot more interactive. But that said, if there are some burning questions that people have as I'm talking, please raise your hand and I'll try and answer them, but then we'll also have some time at the end to talk a little bit. But one of the things I usually throw out into the audience is to have people tell me the difference between Alzheimer's disease and dementia. And the reason that I do that is because I like all of us to kind of start on an even playing field. Because the terms are actually used very interchangeably now, and there are some differences. Dementia is an umbrella term basically that talks about a lot of changes that occur, a lot of cognition changes, a lot of memory issues, a lot of things related to carrying out day-to-day types of activities, those kinds of things that interfere with your ability to do that. Alzheimer's disease is the #1 cause of dementia. So there's actually a slight difference there because there are a lot of things that cause dementia, and we're going to talk about those as we go on. But Alzheimer's disease is the #1 cause. So you can have things that cause dementia. Some of them are reversible. You can have things that cause dementia that may be related, may be totally unrelated to a disease process. But in general, when we talk about dementia, we talk about an umbrella term that encompasses a bunch of symptoms. Dementia is not a normal part of aging. A lot of times people think that just as you age and you start to have problems remembering things, that that's the same as having Alzheimer's disease or having dementia, and it's not. Dementia is not a normal part of aging. There's a difference between forgetfulness and memory loss. Forgetfulness is where you forget to put your keys, or you put something down and you forget to go pick it up again, or you do something. Eventually you remember what you did, you're able to backtrack your steps, and you're able to find that, or you're able to remember that. Memory loss, on the other hand, is something where you actually forget an event. You actually forget that something occurred, and that's very different. So it's not like you can go back and retrieve that information because it's like it never happened. Or unlike forgetfulness, over a period of time, you'll generally remember. And actually, as you age, there is a little bit of a variation in terms of your ability, the speed to recall information. So that may take a little bit longer just because, just like everything else as you age, things are a little bit slower. So those neurons take a little bit more time to fire up and kind of retrieve that information. But generally, you're able to pull back and find out what you need to know. Yes?
Can you have dementia without Alzheimer's?
Yes. And we're going to talk about that. This is just some information about kind of the history of Alzheimer's disease. It was first diagnosed or discovered by Dr. Alois Alzheimer's in 1906, actually on a 53-year-old female, which at that time was fairly old. Not anymore, at least from where I stand. It's the #1 cause of dementia. Currently in the United States, there are 5.3 million people with Alzheimer's disease. It is now the 6th leading cause of death. Age is the primary risk factor. That's often a question that I get. So basically, the older that you get, the higher your risk goes. So just as a quick little study, pretend we're all 85 years old in this room. I'd like every other person to raise your hand. So start here with the lady in the white. Every other one. Keep them up. We're going to go all the way around the room. Green, raise your hand. Pay attention. It's plaid, pay attention. Here you go. Okay. Just like doing the wave, only other one. Close enough. Go ahead. Keep them up. Keep going. Keep going. Keep going. Somebody in the next row. Okay. Next row. Keep going. Apparently this group over here is not. Okay, I see them. Okay, keep going, keep going, keep going, keep going, keep going. Keep going. We're almost done. Keep your hands up. Keep going. Almost there. We're almost doing it. Come on, come on, come on. Okay. Can't see the people out in the hallway. I want you to look around you. See how many hands are up in the air? If you're all 85 years old, that's how many people are going to get Alzheimer's. By the time you're 85 years old, you have a 50-50 chance of developing Alzheimer's disease. Okay, you can put your arms down now. Kind of gives a whole different perspective, doesn't it, when you look around and see that many people? Well, I got news for you folks. I'm part of the baby boomers, and there's a whole bunch of us coming. So geriatrics is really kind of a good place to be. Some of the hit the wrong button. Some of the characteristics of Alzheimer's disease, and this is one of the hallmarks that Dr. Alzheimer's found, is these plaques and tangles that developed in the brain. And they're related to proteins that kind of go awry and wind up eventually strangling and dying within the brain. And when that happens, it cuts off the blood supply to the brain. And when there's no blood supply going to the brain in those areas, those brain cells die. So those little nerve cells that interact and have those little electrical impulses that help us remember things and do all the things that we do throughout our day die off. And when they're dead, they can't function. Yes?
Would the plaque be different from the plaque
I don't know specifically, but there have been some indications that there's some similarities in that, so that health-wise it's a good idea to stay healthy that way too in terms of keeping an eye on that. Same thing with plaque on your teeth and plaque in your arteries. They're kind of all related. Did that answer your question? Okay. As these plaques and tangles start to kind of filter or start to populate in the brain, some of the things that happens as the end result is you see the changes in memory, thinking, and behavior. And one of the things I want to talk a little bit about before we go to the next slide too, is that when people think of memory, it's not just, and we think of memory loss, we think of forgetting something. And I mentioned earlier that there's a difference between memory loss and forgetfulness. But what happens is people start thinking because a person can't remember something that happened a few minutes ago, that somehow that's isolated from memory. Where's that going? If you think of memory as a spider web, and all the little pieces of a spider web that go out from the center, memory is based on, everything that we do is based on memory. So every morning when we get up, we don't have to relearn how to put our shoes on. We don't have to relearn how to brush our teeth. We don't have to relearn how to comb our hair or to take a shower. We kind of build on those things. From the time we're born and we start learning things and functioning that way, that's part of memory. So we don't have to start from the beginning each day. What happens with Alzheimer's disease and some of the other conditions that cause memory loss, because it hits different parts of the brain, and I'm going to show you some things about that later, but it starts infiltrating all parts of the brain, and the only way that we know that things are happening in the brain is through behavior. So to isolate memory is pretty hard to do because everything we do is based on memory. I worked with a man one time that was trying to put his shoes on. He knew what his feet were, and he knew what his shoes were. He had no idea to get him on how to get that on his feet. Because it's that connecting information, and that's memory. So when things start to break down, when those pieces of memory start to be disconnected, it's more than just forgetting where you put something. It's more than just forgetting where somebody's name is. It's putting pieces of information together that we use all day long, throughout the day, throughout our lives. And that's where it becomes problematic when a person tries to complete tasks that they've done for a long time or try and remember things. So it's not just remembering specific pieces of information, it's remembering all of the things that connect together that we do throughout our life and throughout our day. These are some of the causes of reversible dementia. These are things that I call that are generally environmentally induced. And that means that once you've addressed the problem or once you've addressed the condition, there's a pretty good chance that the condition's going to be resolved. So things like emotional distress, anxiety, when it gets overpowering and kind of becomes debilitating. Depression is a huge one because a lot of times depression really mimics it. And sometimes diagnosis for Alzheimer's and other types of dementia are misdiagnosed because people have such a severe, they're dealing with depression in such a severe way. Medical illness like infections. For any of you that have worked with older adults a lot of times have a much more profound and stronger reaction to infections like urinary tract infections and things like that. Generally, if you're working with someone and they seem to have a sudden shift in their behavior and they maybe go from being wherever they were on a normal basis to being much more so, I've even been around folks who actually have looked somewhat psychotic because of infections. So once those infections are addressed, then the condition improves. Medications, either the overuse or the underuse of medications. If you have someone that has a memory problem and they're forgetting when they've taken their medicines, it's a real good indication, or there's a real good chance that those medications could be causing the problem. So once the medications are stabilized, a lot of time the cognition comes back to where it was before. Or if somebody's reacting poorly to a medication. Maybe somebody's having an allergic reaction to a medicine that they've never had before. So it's important to have a baseline so if you see sudden changes occur, often they're environmentally induced unless it's something like a head trauma. Nutritional deficiencies, people not eating properly or eating the wrong things. It's not unusual for folks as they age to want to eat things that are easy. So you see people eating cookies and things that are finger foods and easy, particularly if you've got someone that maybe is living by themselves. And substance abuse. Probably the oldest person that I've worked with that had a cocaine issue was about 86. So it's not just for young people. These are some of the irreversible causes of dementia, the more ones that are more pathological in nature. Alzheimer's disease is number 1. Dementia with Lewy bodies and vascular dementia are really kind of neck and neck for number 2. Lewy body dementia is actually kind of associated with Parkinson's. There's some rigidity and things like that sometimes are associated with it. Lewy body dementia has more of an association with also your people have a tendency to be more susceptible to visual hallucinations. And so it's important to know that because a lot of times those kinds of behaviors are treated with standard antipsychotic medications, and those will have a tendency to make the condition worse, even to the point where some folks have actually died because they've had such a strong reaction to the antipsychotic meds as they're trying to treat that. Because generally what will happen as a rule of thumb is a person will be started on a certain level of antipsychotic medication, the symptoms don't improve, so what happens then? You increase it. And doesn't get better yet, so you increase it again. So it's important to know that if you're treating someone that you need to have an idea of to take a look for that. Vascular dementia, also known as multi-infarct dementia. That's when you've all heard of mini strokes? CVA, okay. That's when a lot of little blood vessels in the brain start breaking systematically from tiny little strokes. People are not always aware when they're having the strokes, and other people are not necessarily always aware when they're having a stroke because they're so small. But you get a lot of them over a period of time. And also keep in mind that particularly all the top 3 there, unless you have a major vascular accident, a stroke, that these are very systemic and very slow acting. So a lot of times people actually may have had the disease, but it's not noticeable for maybe 7, 8, 9 years. Generally after diagnosis, it's roughly around 8 to 10 years when people go from diagnosis to dying. Fortunately, that's getting a little bit broader because people are starting to get diagnosed a little bit sooner, which is a really good thing. Parkinson's disease, not everyone will have dementia related to Parkinson's, but it's a high risk. Frontal temporal dementia is in the front part of the brain. Often this does not have the profound memory loss that's often associated with some of the other dementias. So you get more behavioral changes because that's where a lot of the executive functioning takes place. And I'm going to talk a little bit more about the brain stuff in a minute here. But often those folks are younger. I mean, I had everybody raise their hand as if you're 85, but actually there's a percentage of folks that that develop Alzheimer's disease as young as in their 30s and 40s, and that's called younger onset Alzheimer's. And that is the one that has really the highest genetic link. Normal pressure hydrocephalus, that's where you have the water on the brain. Mixed dementias, you can have more than one kind of dementia going on at the same time. So you could have any one of these. There's also roughly 80 other types of things that can cause dementia. These are some of the warning signs. Through the Alzheimer's Association, these are some of the things that people call and ask us about, and we have this information. And by the way, if you're ever interested in finding out a little bit more, if you go to alz.org, there's a really nice website and can give you a lot of information on a lot of this stuff. It can even take you through, as you can find the Alzheimer's Association nearest you, along with some other information. alz.org. Memory changes that disrupt your daily life. So things that you used to be able to do easily are starting to have problems with those. Challenges in planning or solving problems. And keep track of these things as we go. Well, I see you're writing, but kind of keep in mind, because when we get into some of the brain stuff, you'll see where this starts to play. Difficulty completing familiar tasks, confusion with time and place, trouble understanding visual images and spatial relationships. We do some training with folks for caregivers, actually. We do a lot of work with caregivers. And recently I was doing a training, and the lady that was taking care of her husband was explaining about how it was very difficult. She was having a hard time getting him into the car. Because even though they'd go up to the car and she would try to explain to him how to get his feet in the car and shut the door, it just wasn't clicking. So as that happened, we went back. Is it echoing or is it just me? Okay. Anyway, she was trying to get him into the car. So we started talking about one of the things that happens with a person's brain is it changes in terms of their ability to understand language and interpret language, because a person can still be able to read and recognize words, but they lose the meaning of the words. And often, because we're such rational characters, we think that if we just use the right words, or if we put them in such a right way that we can convince the person, or we try and reason with the person and rationalize why they should do this or why they shouldn't do this, and that actually only confuses things even more. Because as the brain changes and the ability to understand language and conceptually and abstractly look at things, that becomes more complicated. So really, as a person's dementia progresses, the more you try and use more words, the more it makes it more confusing. So, yes? Not necessarily, because again, I always tell folks, if you've seen one person with memory loss, you've seen one person with memory loss. There are some characteristics and some patterns, but there's going to be certainly some individual differences, just like all of you in this room. There are certainly some characteristics. You're all in school, you're all here because you either needed to or you wanted to or you're getting extra credit or whatever. But your all individual reasons for being here are very different from the person next to you. So that's how different it is persons with memory loss. Often what we'll try and say is use different mediums of communication. So sometimes as the person's dementia progresses and they lose some of those language skills and those interpretation skills, using more than one way of communicating. So you like using pictures. For example, when I worked in long-term care, would have a picture for the bathroom, would have a picture of the toilet, and then would have bathroom or toilet or whatever underneath that. So the person, and plus, we'd usually try and leave the door open so that there was a visual cue there. Because you try and tap into the person's strengths, things that the skills and the abilities that they have left. So you try and tap into those to help that person stay as independent, as functioning as possible. So using just the symbol or using just the word may or may not work. So it's just trial and error. When I work with caregivers and we're looking at some problem-solving kinds of things, I always tell folks to get a bag of tricks. And what that means is that you may use something that works like a charm one time, try it the next time and you fall flat on your face because it just doesn't work. Don't give it away. Don't throw it away. Just tuck it away. And that another time, try it again. But back to my story about the gentleman that was trying to get in the car. And once we talked about how language skills and how even though a person can read, they may not understand or know what that word means or the words that they're saying mean. So we came up with some problem-solving things and gave her some suggestions about going up to the car, because she was instructing him before she would get out there to go get in the car and open the door and sit down. There were too many things that were happening. So he would just kind of stand there, and then she would try and get him going, and he just was having a hard time following through with the instruction. So what we wound up doing is having her try to take him with her out to the car, open the car, and then just pat the seat. It's a visual cue. Once he saw that and you eliminated some of those words, it was a piece of cake. She came back in and was just thrilled that they were able to get in and out of the car now, because she had shifted. And the only way that you can change the behavior of someone is to change your approach to it. Because to expect someone with memory loss to change their behavior, when they're conceptually, there's not a problem. I mean, from their world, there's not a problem. You have to change your approach. So explaining to someone why they should or should not do something isn't going to help. It's just going to kind of complicate things. So if you want to change the outcome of a behavior, you need to change your approach. We talked a little bit about the problems with words just now. Replacing things and losing the ability to retrace the steps. That's kind of like the forgetfulness versus memory loss that we talked about. Judgment. Withdrawing from work and social activities. It's interesting, it's kind of like a lot of things that in retrospect, you know, they always tell you have 20/20 vision in retrospect. And often once a diagnosis is made or once you kind of know what's going on, when you talk to families, they'll backtrack and they'll say, you know, about 5 years ago, or about 6 years ago, or about 3 years ago, I started noticing these changes. But unless you have a context to understand what those changes mean, it's hard to know what's going on. But in retrospect, a lot of times people will mention things like the person withdrawing from work or social activities. And then changes in mood and personality. And again, all of these things are related specifically to changes in the brain. We're not going to get into this too much, so I don't want you to think we're doing anatomy here. But I did want to give you an idea of some of the things that impact the brain and the behaviors and that sort of thing. And these are just, it's just going to be a kind of a quick thing about the brain and how it functions. The brain's, and I got some pictures later on, and they're in color, so we're good. The brain's divided in two halves, the right and the left hemispheres. Each hemisphere is divided into 4 lobes: the frontal, temporal, parietal, and occipital. Okay, the frontal lobe, which is right in here, that's where your executive functioning is. That's what allows you to organize. That's what allows you for impulse control, kind of prioritize your tasks, your judgment, knowing when to do what and what's appropriate or not appropriate, your social skills, how to act in a certain way, all those kinds of things. Those all take place in your frontal lobe. Long time ago, they used to talk about things like a lobotomy for violent prisoners. Okay, that's where the lobotomy would occur. And what they used to do is there was surgery that they would do on the frontal lobe, because if somebody was aggressive, that was one of the ways that you would help control that, is by altering that frontal lobe. So if you hear a lobotomy, that's what that meant. They would be doing surgery that altered the frontal lobe. Yes? The question was did that kind of result in a zombie-like thing? Probably in some people. I mean, it certainly flattens your affect. And depending on how sophisticated the surgery was, which probably wasn't too much at that time, and they didn't really do it for very long. But That I don't know. Most of the stuff that I've heard is when there were probably either mental health, mental patients or prisoners that were very violent. That was generally before the use of medications and psychotropics and things like that were more behavioral management oriented. The temporal lobe is on the side of the head, and that is where we have understanding and interpreting speech. So part of what we do, and keep in mind all the brain parts work together, but this is kind of where these functioning pieces go. But that helps you understand and interpret what you're saying, kind of integrating all that information. So what you hear, understanding that, and being able to know what that means. So that's a pretty high functioning kind of thing. Parietal lobe is near the back of the head. That's your visual spatial. It integrates the senses and allows for understanding of a single concept, putting all of those things together. So like if you smell smoke out in the hallway and you hear an alarm, what does that tell you to do? Yeah, you're taking that in. You're not looking. You're not taking those pieces of information individually and like, what does that mean? You're able to take that information, integrate it together, and then your judgment comes into play, and hopefully will tell you not everybody to take off at once, or somebody is going to wind up getting trampled. Prioritizing, how to systematically do something. Those are some of the things, how the brain's working together. The occipital lobe is in the back of the head, and that's where you have your visual interpretation. So when you start having problems with somebody recognizing visual objects or interpreting that, there may be some things going on in the brain. An example of some of this was my dad was a truck driver. And I'd worked with people with memory loss for a long time before my dad started showing signs of memory loss. And he had vascular dementia, so he had the little mini strokes going on in his brain. And he had been a professional truck driver for a very, very long time. I used to call him my own little MapQuest before MapQuest was MapQuest, because I could ask him where I needed to go, and he would tell me the best route to get there and get me there in the best time and all this other kind of stuff. Well, my parents lived in the same house for 50 years. I grew up in southern Michigan in Three Rivers, so it's not a real big town if any of you have ever been around there. So he had about a 2-mile run every morning, which was his habit to go in and have coffee with his friends every morning about 6 o'clock. Well, he wound up having a right cerebral hemorrhage, which basically is a stroke in the right side of his brain. And this was in addition to the mini strokes. But it was one of the big turning points for him, because what happened after he recovered and came home, even though he could walk fine, he didn't have any weakness in any of his limbs, his speech was not impaired, he didn't have any drooping or anything like that. When he would get in his truck to go down to have coffee with his friends, and there were 2 turns, he would get lost. Because the part of his brain that controlled his visual, spatial, and his ability to recognize and interpret where he was in space and to be able to navigate and get back and forth to where he needed to go was damaged. That was the part of his brain that controlled that ability to do that. Physically, he could drive, but he would get lost. So that was one of the things, the primary thing that led to him having to give up his license, because he was getting lost. There were other things too, but that was probably the primary one. But that's a really good example of when you have a damage to a certain part of the brain, how that fits into the whole brain and how we function in our world and in our environment around us. So by his damage to the right side of his brain, it interfered with his day-to-day functioning enough where he would get disoriented and lost. So even if he was with other people and they were going places, he would have no idea in terms of environmentally around how that would help him navigate in that part of the world. The hippocampus is kind of in the center of the brain. And this is the part of the brain that as you're getting new information in, it's kind of your short-term memory. And short-term memory, in order for you to be able to retrieve it, has to move into long-term memory. And if you've got damage in the hippocampus, it never has the ability to move into long-term memory. So one of the things that interferes with your ability to remember things, if you have Alzheimer's disease, is there's generally damage that's going on in the hippocampus. The cerebellum is at the base of the skull down here, and that's one of the things that helps coordinate your voluntary movement and your balance, kind of how you move about. And then in the brainstem, that really controls all your vital functions. So as a person in the very later stages of Alzheimer's disease, before they die, generally will have difficulty having breathing regularity, having your heart rate being so that the heart knows to keep beating, swallowing reflexes, your blood pressure, all of those kinds of things. Yes?
Can you have just one of those go bad, but really not have dementia or Alzheimer's?
I don't know.
Like
My guess would be...
short-term memory that go into long-term. How would you know to treat them?
Through behavior. I mentioned earlier that the only way that we know that there's changes that go on in the brain initially is through behavior. So how people act, how they respond within their environment. My dad, for example, one of the ways that we knew the part of the, I mean, other than the CAT scans and things like that, but we knew that that part of the brain had been damaged. Other parts of his brain were damaged too. It's very difficult to have an isolated damage to the brain and have an impairment to the point where it interferes with your ability to function in your environment without having some residuals in other parts of the brain. Particularly with the types of dementia that we've talked about, it's very seldom isolated. Okay, see, I told you there were pictures. Okay. Here's the frontal lobe here. That's your executive functioning. The parietal lobe, this looks way different than it does just talking, doesn't it? Down here is your little hippocampus. So that kind of gives you, here's your eye right there. Looks just the same, don't you think? But anyway, this just gives you an idea of how the brain is laid out. And the importance of that is not for you to remember every single one of these kinds of things. That wasn't the point in bringing this to you. The point in bringing this to you is that as the brain is impacted by any one of these forms or any one of these causes of dementia, any one of these disease processes, that it has a pretty high risk or a pretty good chance that all of these different pieces of the brain are going to be impacted to varying degrees. Now, granted, you could have an injury from, for example, you have a head trauma, and maybe you bump the front part of your head here pretty hard. Chances are you're going to have more profound damage or more of a profound impact from that part of the brain because that was where the original insult was. Is it going to impact other parts of the brain? Probably, but not necessarily the same as it would if someone had an Alzheimer's type disease or if someone had a vascular dementia, because it's going to be spread out or it's going to be impacting the brain a little bit differently. But it's kind of all of these pieces that work together that kind of help us live in our environment and work. And when you start having damage or you start having some interference in any parts of those brain, the way you're going to know that is through the behavior. Here's an example of a brain with Alzheimer's and one without. You'll notice how different this one looks in terms of the spaces in between the little parts of the brain. Generally, you see it fat and fluffy like this. But here there's more separation. And actually, if you were to take this brain and cut it, a cross-section of it, often you'll see even just holes in the brain. Yes?
Does that result in a reduction in the number of cells?
Yes.
Is that the white matter of the brain that's usually destroyed, such as like axons and dendrites?
Yes. Did you have a question? Okay.
Is that something that can be felt? I mean, do they?
No.
You can't?
No. Actually, the brain, as it ages, will shrink a little bit. Not necessarily to this extent. And actually, I've seen brains that are much more impaired than this one, where there's really not much left. And if, like I said, if you do a cross-section of it, you'll actually see kind of parts of the brain that are missing. You had a question?
So it affects the short-term memory, not the long-term.
That's a really good question. Her question was, does this affect the short-term or long-term? And it affects both. The short-term memory is things that you have immediate recall. So if you're going, I don't know how many of you have ever visited parents or grandparents or aunts or uncles, but you'll go in there and maybe you've noticed that they've, just came to you after they've eaten dinner. And one of the comments they'll make is, I don't know why they don't feed me around here. And they just ate a few minutes ago. That's short-term memory, the inability to recall that and understand. There's judgment involved with that somebody would be not feeding them. There's all kinds of parts of the brain that are being used. But the fact that they're not able to recall that short-term information is a pretty good indicator that something's going on. The long-term memory, though, people will talk about, and actually there's one of the questions that I put at the end, because I put some questions that people normally ask me, is the ability to retrieve information. And one of the ways that you can actually have some information or an indication of how far along a person is in their memory loss or in their dementia is that it goes backwards. So the most recent is going to be the most current that's going to be lost, and it'll go backwards. So sometimes you'll see that someone with memory loss will call their daughter or their son a spouse or another relative. Or you'll hear somebody say, I have to go, particularly in long-term care, you'll see folks wanting to go home, or you're wanting somebody that's in their 80s or 90s or so, being very upset because they have children waiting for them at home and they have to get home. So they'll be able to recall events that have happened a long time ago, and they're living them as they are now. So if something like that happens, your response to that will often drive the outcome of that interaction. Because if you say, well, no, you don't have any children, you have grandchildren or whatever that are this old, and you don't live there anymore, be very careful about making those kinds of statements, because that person is living in a very different place than you are. And to expect them to be able to understand the same kinds of things that you're talking about and reason and rationalize, that whole front part of the brain thing. So there's reasons that they're responding that way. It's not because they want to do that. It's because they live in a very different reality. It's kind of like looking out the same window but looking in different directions.
How would you handle a situation like that?
Like what? Oh, like the...
Like the example you just gave.
I personally would probably not disagree with them. I would probably redirect them and say something like, that must be pretty scary to have your children being at home when you're not there. Tell me about your children a little bit. So you can use a person's memory loss to your advantage, because they're generally distractible and redirectable. Because and that's where it comes, it's a good idea to know the people that you're taking care of if you find yourself in that type of a setting. Because you could create a catastrophic event right then if you're not careful. Because if a person doesn't remember that happening, or if somebody is looking for a spouse and or a parent, and you turn around and say, your parent's dead, why are you, asking me that question? That's a pretty traumatic thing. I mean, if you think about yourself, and all of a sudden somebody come up and said, well, your mom or dad's dead. I don't know what you're talking about. They died a long time ago. That's not your reality at that moment in time. And when you're working with somebody with memory loss, you meet them where they are. You don't try and bring them into your world, because if they could be in your world, they'd be there on their own.
What about the anger issues that goes along with dementia? Is that more the behavior of being frustrated, or is that due to what's being affected in the brain?
The question was, when people have, I'm going to paraphrase, when people have issues with anger as a result of the dementia or some other kinds of things that are going on in the brain, is that?
Right.
Okay. Yes, there can be mood changes and behavior changes. I worked with a gentleman one time that had been a pastor in a town, and he was very well respected, very proper, very, just a really lovely, nice man, very caring. As his dementia progressed, some of his behaviors were things like being overly familiar with some of the ladies that were there, disrobing in public places, Things that were offensive to other people in his world, he couldn't understand why that was a problem, but it was offensive to his family. Not in that they were angry with him, but they were terribly hurt because there were some behavior changes that were related to his changes in his brain and his cognition that interfered with his judgment, that interfered with his ability to make good decisions, his ability to integrate all that stuff that was going on around him and knowing what was right and what was wrong. All those impulse controls and those kinds of things were damaged. Sometimes that translates into anger. I've also seen people that have had histories of being very aggressive, calm right down. So again, it kind of goes back to that if you've seen one person with memory loss, you've seen one person with memory loss. But know that there are some things that can happen that way. Yes and no is pretty non-committed answer. It's helpful just to know the person that you're with and know that that could be part of the problem. Called what? I'm not familiar with that. Doesn't mean it's not something that people use. Generally, I'm more familiar with immediate recall and then short-term and long-term. But it sounds like it's probably about the same. The lady with the stripe. Oh, the buddy system. I love it. Okay. Yes.
Is it generally characteristic for somebody with Alzheimer's to eventually forget their children?
Yep, they can. Often what they'll do is either forget that they've had children because they're in a different place, or they will interpret their children as a spouse or something like that because that's where they are. There's something called procedural memory that allows people to, I call it what the mind forgets, the body remembers. When I was a kid, we didn't have seatbelts. That's how old I am. And when I would be in the car with my mom and we would come to a stop sign or come to a stop where we had to stop quickly, I see kids doing it, the arm went out. As an adult woman, when I would be in the car with her and she was driving, and even after we had seatbelts and all kinds of harnesses in the car, if we had to come to a quick stop, guess what happened? Arm went out. It wasn't something that she thought about, but it was a reaction that was there. We see that, for example, with another example would be if somebody is kind of angry or have some of the behavioral kinds of things. You get that person into church in an environment that's where there's expected behaviors in that environment, and guess what happens? It goes right down, and they behave appropriate to that situation. Did anybody have to tell them that? Not at all. But there are situations where people can rely on that procedural, that behavior, that muscle memory kind of thing. There was one other question I think I missed. Yes?
Have you ever seen where they know they're losing their memory?
Sure. People with memory loss aren't stupid. I mean, they have memory loss, but they're not stupid. And yes, generally earlier on in the disease process, people know that things are not happening. In fact, we had a conversation about that over lunch, about the pros and cons of getting a diagnosis early or finding out early, and we're actually going to talk about it a little bit. But what they found is that when people recognize that they're having problems with their memory and they go and have that checked, the original hypothesis was that people were going to be more depressed if they found out that they had Alzheimer's disease. And what happened is they found out the exact opposite, that people had less depression once they received a diagnosis. Because it's like any other kind of illness. I mean, why do we go to doctors in the first place? It's because something's going on and we want to find out what's wrong with us. So when somebody has Alzheimer's disease, it's not because they don't recognize problems. And granted, there's always going to be folks that are going to deny it and blame somebody else and all that other kind of stuff. But eventually, people like to know because it gives you a sense of control. It gives you a sense of being able to plan and manage and basically take more control of your life. So someone that has memory loss that gets a diagnosis, the probability of them not being depressed is greater than being depressed. Yes?
If you change environment, is that progressive? Or if, like,
It-
I'm just wondering if changing the environment and putting them into a different environment would,
When you change an environment with somebody that has a memory impairment, it disorients them. I don't know of any incidents where it's actually progressed the dementia, but because if a person's familiar in an environment, they know everything about their environment. I mean, they're comfortable in that environment, so they behave accordingly. If you put someone in a new environment, there's a certain amount of anxiety, there's a certain amount of becoming acclimated and learning about your environment. And when you have impaired senses, that takes longer. So generally after a period of time and a person's had an opportunity to reacclimate and become familiar with the environment, they usually settle in. I used to tell folks when I worked in long-term care in the dementia programs, I used to tell folks, give them at least 6 weeks. Because it takes a period of time for that to happen. Because it's not like a person can cognitively get used to that and have self-directed activities and things like that. They have to get used to the environment.
What if that keeps changing?
That might be a little disconcerting to the person. I don't think I would recommend changing all the time. I think that there are sometimes you can't avoid that, and there are some circumstances that require people to be moved to a new environment. It would be best to try and minimize the number of times that happens, but
Well, maybe not so much the environment she's in, or the environment where she's at keeps changing. It's not that she's going to a different place. I mean, how bad can that be on her?
it can be disruptive, and a lot of times that'll come out in problem behaviors, because if the person's not able to assimilate, then they're going to have, that's generally what happens. What time am I supposed to quit?
2:45.
Okay.
1:15 to 2:45.
Okay, just checking. Yeah.
I know this is another question in the series. On the note of acclimating to a new area,
Mm-hmm.
is there a problem with encoding new memories when you have Alzheimer's, or is it just with the
There are a lot of interesting things about that. Generally, what happens is when I talked about procedural memory, a lot of times you can, with repetition, help a person know how to retrieve information without actually remembering the exact information. An example, I worked with one of the crisis homes here in town that worked with mentally ill folks. And we were doing some problem solving because they had a couple of residents that were living there that every 15 minutes, and these were older adults, so there was issues of mental illness but also of dementia, were coming every 15 minutes to want to know what was for dinner or what was for breakfast. And the staff was getting pretty irritated with that because it was disruptive to a lot of routines, because it was just this repetitive asking. So what we wound up doing is we got a whiteboard and put it up by the desk, and there was an assigned responsibility of someone to write on that board what was for breakfast, what was for lunch, or whatever, or each one meal at a time. I don't recall exactly, but the point is that you need to make it big enough for people to read. Because a lot of times if you've gone into long-term care facilities, they'll say they have a calendar, and it's like this big. Okay, well, that's pretty much useless, so that needs to go. That's another story. Anyway, but put it up so people can actually read it, and then when the person would come and ask the staff member what was for breakfast or what was for lunch, what the staff person would say was, why don't you go look at the board? Why don't you go look at the board? And everybody had to do that. So after a period of time, what happened, as opposed to the person coming and asking the individual staff members, guess what they did? They went to the board. Because they couldn't, they did that multiple times, but they didn't have to remember the specifics of what was for breakfast. They just had to remember where to go to get it. So in that context, you can do that same kind of thing with people with memory loss. So it's not the same as retaining large pieces of new information, but it's a process of helping people get to the information that they need. Yes? It's generally the later stages of the disease, but often what will happen is people will make people dependent because it turns out to be a lot faster to do something for someone than it does to help them do it themselves. And people get frustrated, and that's understandable when you're living with it 24/7. If you're a full-time caregiver, whether it's a family person or it's generally more likely with a family person. And so in order to get on with the task, people will do things for them. That creates a dependency, so a person loses those skills. It's kind of if you don't use it, you lose it sort of thing, because you lose practice. So there are lots of things that can be adapted. Often what will happen is people are I don't think they're resistant, but they don't realize that you can break down tasks in a different way so that the person can complete it, that because they don't do it the same way that they've always done it, that there's not alternatives to that. And so when they don't do it the same way they've always done it, it's interpreted as they can't do it anymore. And again, it kind of goes back on the caregiver is to adapt or adjust how you're presenting that information, or you are changing your expectations of the task. So for example, I'm going to use something really easy and silly, but bingo. It doesn't take too long for a person with memory loss to have difficulty with that for a number of reasons. Number one, some visual spatial kinds of things. They may not be able to physically read what's on the bingo chips. They might start having some difficulty with dexterity because it's not uncommon for old fingers to have arthritis and have a little difficulty grasping things. They may lose the ability to make the association between that number that's written on that disc and something that's on the table that has that same number. So there's lots of things that are fairly sophisticated that a person loses the ability to do that. Does that mean they can't play bingo? Not at all. What you can do, though, is you can adapt that activity. So you could go from a progression of, say, like matching colors. You could match shapes. You could match a lot of different things. Doesn't have to be bingo numbers. But what you can do is still engage that person and still allow that person to be productive and have a failure-free experience with that without sticking with the traditional bingo kind of thing. And you can pretty much take that with anything that you do, and adapt it to a certain degree so that the person's able to accomplish that. So for example, if somebody's having difficulty getting dressed, does your shirt have a lot of buttons on it? Because chances are lining up those buttons and that fine motor skill that's going to take to button those buttons are going to be a problem. So what's an alternative? Shirt that goes over the head. Okay? Same thing with pants. If somebody's having a difficult time with buttons and zippers, guess what? There's pull-up pants. And these sound pretty minor kinds of things, but it's a big deal to somebody to be able to maintain that level of independence. It doesn't make any difference how old you are. I mean, we're talking primarily about older adults, but if you think about it as yourself, in terms of the dignity that you have of being able to do something on your own, regardless of your age, or having somebody do that task for you, it makes a big difference. It's not just older adults.
So then why would it be that if somebody with like an anger problem or a behavior problem can immediately adjust if they're placed in a church setting, but they can't, I guess I'm not understanding why then they can't figure out how to line up a button.
They're totally different activities, totally different parts of the brain in use. One is coordinating motor activities, so willing your fingers to do what you want them to do, and the dexterity of all that involved because it's pretty sophisticated. The other one is behavior in terms of how to act in an environment.
And then why would it be that that is so imprinted in somebody's brain that they, even with Alzheimer's, they immediately can adjust to that church setting? What would be, is there any research that shows why that is?
I'm sure there is, it's just not coming to mind right now. But basically there are certain behaviors that stick with us longer than other kinds of things. So the example that I gave about the arm, they're not things that you think about, there's things that the body has just remembered, and they do it automatically. We all have them in different situations. We all have them. Those kinds of expectations and behaviors are things that are just ingrained in us, not in a bad way. They call it muscle memory. They call it whatever. There's lots of things. It's kind of like if you go up to a stove and you see it's red and you start to touch it and you feel the heat, you jerk your hand back. Did somebody tell you to do that right at that moment? No. I mean, there's lots of things that we see that we anticipate there's going to be. I mean, for crying out loud, look at any scary movie and you kind of know by the music and stuff when it's coming up, and it's like something's going to happen. So there's all those kinds of things that we become used to that the body just responds to. Yes?
With that, just for an example, I deal with clients every day like that, and a good example of that is they don't know that they need to use the bathroom, but if you bring them to the restroom
Yes.
every 2 hours and have them sit on the toilet,
Mm-hmm.
that feeling of the toilet
Mm-hmm.
seat, now they know what to do.
Sure, it's the cueing. It's the cueing. So yeah, so I mean that's a really nice example, thank you, of how the body remembers how to do things, but the process sometimes becomes different. Here's another example. How many of you know how many steps it takes to brush your teeth? Kind of the same thing. Take a guess. 2. I've heard 2 and 10. Any more? Going. What? There's over 100. Imagine that. You know why there's over 100? Because it's a pretty sophisticated thing, and you just don't think of it that way. First of all, and I'm only going to do the shortcut. I'm not going to do all 100 because we don't have that much time. But first of all, you have to have some conceptual, that that's what you need to do with your teeth. That you have teeth and you need to take care of them. That's a concept. So not only do you need to have that idea that you need to do something about that, you need to know what equipment you need, and you need to know what to do with it. I can't tell you how many times I've handed a toothbrush to somebody with memory loss and they started combing their hair. Seriously. Because it's an instrument and they forgot what the use of that is. So you need to know that you need to brush your teeth, you need to know what you need to know what to do with the tools. You need to go where to go to brush your teeth. Where's appropriate for that? Where those things are kept. You need to know you need things like toothpaste, and you need to know that the toothpaste goes on the toothbrush. And you need to be able to recognize your toothbrush because there's lots of different kinds of toothbrushes out there. You've got electric toothbrushes, and you've got all different colored toothbrushes, and you've got different shapes of toothbrushes, and everybody has their own special kind that they like. So you need to know all that stuff. Then you need to be able to physically put that toothpaste on there. Now that you know what it's for, you have to be able to coordinate these 2 hands or some other way of getting that toothpaste on there. Once you get it on there, you need to know that it doesn't go in your hair, it goes in your mouth. And then you need to know once you get it in your mouth, you got to move it around and brush your teeth and all this other kind of stuff and take some time doing that. Then you have to spit that toothpaste stuff out. Then you maybe have to do a little bit more. And then you have to rinse it out. And then you have to take care of your equipment and put it away and leave. That's a lot of stuff to remember, and we do it without even thinking. But somebody that has memory impaired, somebody that's had their spider web destroyed, where all of those little pieces of connecting information have been damaged, and they're not putting those pieces together, like the man that was trying to put on his shoes but had no idea how to get his feet in those shoes. Had no idea. That's very common. Rationalizing with a person saying, well, why don't you know that? Of course you know this. Isn't going to help. Saying to someone, well, don't you remember? Isn't going to help them. Should try and refrain saying that if you know someone with memory loss. So those are the kinds of things that we take for granted but are really very sophisticated. Yes?
You had earlier about your dad had many strokes, and you talked about dad stroke. So how, and everything else we talked about is behavior. How do you know if it's a stroke or various
Oh, sure. I mean, there were CAT scans and there were other medical indicators that he had had a stroke. So there was no question about that. We saw the brain scans and that kind of thing. Plus he was at risk. He had high blood pressure and other kinds of things. So, and it looks very different than a seizure. And different. Yeah.
Episodes of passing out or.
Yes. Yes.
I was wondering if physical activity does anything to slow the progression or just give them does it just give them a better day? Or is it, because I noticed that with physical activity, there seems to be a lot more clarity in speech and activities. So could you explain?
Generally, yes, and we're going to talk a little bit more about that. But generally, when you have physical activity, you increase blood flow to the body parts and to the brain and all those kinds of things. And that's actually one of the things that helps with alertness. So even though a person may have memory impairment, certainly to have some type of physical activity, it generally will help with things like sleeping problems, agitation, so to speak, lots of kinds of things. Because one of the things that people forget is that someone that has memory loss, if they have they don't have a concept of the future. So that's part of the brain thing that's going on, that a person loses concept of time. So saying to somebody that I'm going to be there in 5 minutes has no meaning. It could be 5 minutes, it could be 5 hours. So conceptually, there's some challenges there. So keeping those kinds of things in mind. Was there some other question? Yeah.
So how does a drug like Aricept help?
I don't know if it hurts. We're going to get into the meds here in a minute, so I'm going to hold back and answer that one in a second. Any other questions about some of this brain stuff before we move on? Yes? Well, after you rule out things like substances and that sort of thing, if there are other health indications, but if out of the blue that happens to you, I certainly would check with my doctor, because that could be an indication of a lot of things. I mean, it certainly could be an indication of a health issue, a stroke, could be something like low blood pressure. I mean, it could be a lot of things. Could be just lack of concentration. It's probably all happened to you where you're busy concentrating or listening to something and you miss your turn, or you turn off on some other street or whatever, and then pretty soon it's like, I don't remember doing here. Often that has to do more with concentration and attentiveness as opposed to something going on in the brain. So if you've got lots of things going on, that's gonna lend itself to that as well. Or if you're in an unfamiliar area, or you're just kind of on autopilot and it's like, guess I shouldn't have been here. So, yes, somebody over here? No? Okay. These are some PET scans of a brain. The brain here on the left, all these little marks here, the bright colors, the red and the yellow, are indications of a lot of activity. The little neurons and all those kinds of electrical energies and inputs firing. This is pretty much what we're all looking like, hopefully, right now. This one over here, you can see there's lots of spaces that are not functioning. And you can't see it probably well, but there's actually some black spots in here, and chances are on this brain scan those are actually open areas or vacant spots. Yeah?
Are those averages over time?
Over time. All of the disease processes that we've talked about, with the exception of like a cerebral stroke, a cerebral accident, or a head trauma of some sort, generally are very slow and progressive. And that's one of the things that's kind of tricky about it, is because they're so slow and insidious that people have a tendency to get used to the behavior, because we're talking anywhere from 8 to 20 years that this could be going on. And so you just get used to the behaviors because they're so slow. You know, I've been married for almost 40 years, so picking up for words that my husband, wasn't saying, or if I'd be starting to say something and couldn't come up with a word and he'd fill in for. I mean, there's little things when you've been in relationships or friends with somebody for a long time. I do the same thing with girlfriends and things like that, that it's just part of a relationship. It's a back and forth kind of relationship. And what happens, because it comes on so slowly, you don't realize it's happening. And then all of a sudden there's generally some kind of a defining event that the aha button goes on. So no, these are not instantaneous unless there's some kind of an accident that happens. But related to the disease processes that we've been talking about, it would be pretty slow.
I meant the aperture speaking for the capture. And like, were the pictures of the brain at one moment?
Uh-huh.
Or was it a picture that had...
Yes, it was a picture of the brain at one, no, it was at one moment. I'm sorry, I misunderstood. These are some things to think about about getting a diagnosis. You start with your primary doctor, and the reason that we always, when we get calls that come into our office about symptoms that are going on and changes, we always have people start with their doctors if they have not met with their doctor to get a diagnosis. And just really getting a diagnosis of dementia really is not good enough. You really need to have a better idea of what's going on rather than just say you have dementia. That's like saying you have a headache. So we start with your doctor. A definitive diagnosis still requires an autopsy. People usually don't want to rush right into that. So, but the current diagnostic tools, and those are listed below, are roughly 80 to 90, 95% accurate because these different tests really look at different things that the brain does. So certainly looking at a physical to make sure that there's no health issues going on, that there's not something that's causing that that's medically treatable, like high blood pressure, all those kinds of things, and I'm going to talk about that in just a second. The neuropsychological evaluation, so going to a neuropsychologist, there's a banter of tests that are used to help identify other kinds of deficits or changes in the brain. The neuroimaging, we saw the PT scan, but MRIs and CAT scans. And something more recent that people are looking at, but not jumping on the bandwagon, are spinal fluid tests because they're able to identify some biomarkers in the spinal fluid now that are indicative of Alzheimer's disease. But it is an invasive procedure, and not everyone is interested or willing to move in that direction at this point. But that particular area is one that's becoming more familiar with folks.
Would that be something more for genetic?
No.
Genetic type?
No, that's different. The genetic testing, there is genetic testing available. It's pretty expensive. Most of the true genetic relationship in familial kind of relationships are generally more related to the younger onset, so people in their 30s, 40s, 50s, anybody younger than 60, and there's often more pronounced occurrence of Alzheimer's disease in those families. Whoop, how far back? That one? Any other questions while we're waiting for notes?
Pretty high with a parent with Alzheimer's that is,
Your risk factors?
yeah.
The question is, are your risk factors high if you have parents with Alzheimer's disease? Yes, not like 90% or anything like that. It's like a lot of other diseases that your risk factors are slightly increased, but it's not 100%. So if you have both parents that have Alzheimer's disease, you have a higher probability, a higher risk factor of developing Alzheimer's disease than if no one in your family or a single parent had it. And keep in mind, you can have more than one kind of thing causing dementia at a time. So those would be things to keep in mind also. Can I switch? Can I keep going now? You all set? Okay. These are some of the areas of research that are currently being done. Things on medication, the neuroimaging I mentioned, genetic testing to find out a little bit more about that, so that people that are interested in finding out about that, if there's a hereditary factor. Inflammation, that's kind of the inflammation in the brain, all those kinds of things that might interfere with blood flow to the brain. Use of antioxidant, herbs, vitamins, estrogen, and behavioral treatments. These are not all of them. See, tell me when. Are we good? Okay. No? You good? All right, I'm moving on. Current treatments, there's no cure. We talked about that. Medications that are out there right now, like the Aricept that you mentioned, generally are focusing on different chemicals in the brain that will help do that. Whoa, sorry, wrong button. Aricept, Exelon, and Razidine are basically the same thing. They're made by different drug companies, but they're all the same thing. If you know someone with memory loss that's been diagnosed with Alzheimer's disease that's on 2 of these, you shouldn't be, because they're the same.
2 of the first 3?
Yep. If you have somebody that's on Aricept and Exelon, they shouldn't be on both of them. They should be on 1 of them. On the other hand, Namenda is the only medication currently that was specifically targeting middle stage dementia, middle part of the dementia process. So you can have Namenda and 1 of these 3. That's very common, is to pair those up.
What do you mean by the middle part?
Later stages of Alzheimer's disease. Oftentimes you'll hear, there's different ways of categorizing it, but often you'll hear beginning, middle, and late Alzheimer's. And so Namenda targets the middle stage that a person's in. Cognex was the first one. You don't hear about this very much anymore. It's a little bit more complicated to administer. You have to have liver tests and all that kind of stuff, and you very seldom hear that. But that was the very first one that was on the market.
If you took a Namenda, though, and say you weren't really in the middle stages, does it have an effect?
Some people it does.
Does it have an effect?
I very seldom see anybody just on Namenda. I generally see people on Namenda and 1 of these other 3.
Right, which the person was, but there was just very high hallucinations
And it's good to know.
took her off the Namenda.
Good. Like any kind of medication, some people will respond to it okay, other people not so much. Just like any medication that you might have an allergic reaction to or whatever. These medications are not unlike that. They're not miracle drugs. They're not going to stop the process of the disease. They help slow it a little bit, but it's not a silver bullet. It may help people regain some functionality, but it is not going to stop the progression of the disease. It's just going to help people ideally live a better life for where they are right now.
What was the chemical in the brain called?
The acetylcholine. There are proteins in the brain that, as there's an overproduction of them, and as they change in the brain, they turn into plaque. And what this does is tries to arrest that. The plaque attacks the brain cells. Yep, that's why earlier on I mentioned that the hallmarks of Alzheimer's disease are the plaques and tangles. They call them neurofibrillary tangles. I'm surprised I didn't trip on that.
When would you normally take someone off of that?
You know, that's something you really need to talk to your doctor about, because there's so many different thoughts about that. If you do take someone off those medications and there's a regression, even if you start them back up, I'm not aware that people are able to get back up to the point that they stop taking them.
So what would be the purpose of stopping in the long period?
Because some theories say that at a certain point they become ineffective.
Right, that's what we
Yeah.
heard. I mean, what would be the benefit of stopping it anyway? If it really wasn't true and we did, then we'd never get that back. anyway.
That's true. And that's why we encourage people to have that discussion with your physician.
Does that prevent oxygen or nutrients from getting to the brain?
It kind of strangles off the brain, yeah, eventually. The nerve cells that have, like the little fingers that go off and the dendrites that go off of it, what happens is it attacks that, and it eventually will coat and strangle those nerve endings or those neutron, and it will cause them to eventually die. Mm-hmm. This was something that just happened recently. I don't know, but why don't, maybe we can talk a little bit more specifically about that afterwards. Okay? Somebody else had a question? Yes? Uh-huh. Uh-huh. I don't know. I really don't know. I just very seldom see it as a standalone drug. Often a person's been on Aricept, and so a physician will add that as the person progresses in the disease process. It's unusual to have a person that far along in the process that's just now being treated for memory loss. So it generally starts with Aricept or one of the Exelon, one of the other ones, and then Namenda is added. Did I go too far, or am I done with that one? Okay. These are the risk factors. Age, I mentioned when we had everybody raise their hand. And it was fun up here to see everybody's look on your face too, by the way, just so you know. So by the time a person's 85, they have a 50% chance of developing Alzheimer's disease. Other risk factors are ethnicity. Populations such as African American and Hispanic populations have higher risk factors, and that's generally because they're not as apt to get medical treatment early on, and it's as a result of some of these other kinds of treatable conditions like high cholesterol and diabetes and blood pressure. So once these health conditions are treated, the risk factors are decreased in terms of in accordance or in line with other populations. But high cholesterol, diabetes, the blood sugar, the high cholesterol kind of talks or speaks to the plaque we were talking about earlier, so keeping healthy levels of that, blood pressure, and then smoking.
What about studies between industrialized societies versus agrarian societies? Because we tend to see high cholesterol, diabetes, and high blood pressure more in industrialized societies than we would in agrarian societies. So what would be the prevalence of Alzheimer's disease? And
I have that information on one of these slides. You'll be surprised. So prevention. Yes, I'm sorry.
Does low cholesterol for a lifetime mean that you're less likely to have Alzheimer's?
I have no idea. I think that cholesterol is one, and I'm not a doctor. From my knowledge, cholesterol is one of those things that can also be a hereditary factor. Okay, and we all have heard stories of athletes that have had difficulty with being at all of their body fat is in line and all this other kind of stuff, and still have problems with high cholesterol, or have had no indications of other health problems, including cholesterol, and have a stroke. So to say that someone that's always had high cholesterol is that it makes them at a lesser risk, I don't know. Or yeah, low cholesterol. I don't know, because there are so many factors that are involved with. There's not just a single factor that is going to give you more of an indication than another. It's a combination of those kinds of things, because if we could focus just on one thing, it would be wonderful. So it certainly doesn't hurt. It would be my guess. It's not going to be the single indicator, but it certainly wouldn't hurt. Yes. Part. I've never heard it being done on a newborn. There are some genetic tests that can take place, but they're fairly expensive. most of the folks that I'm aware of that have pursued genetic testing are ones that have a high prevalence in their family. And I'm not aware of anybody in Grand Rapids that's doing the genetic testing, but I've not really looked either. I haven't had anybody ask about that lately. Yes?
I asked our neurologist, and he said because I have aunts, uncles, aunts, and family members, and they won't do the testing at this time in Grand Rapids due to the fact that genetically it's still not proven.
Right.
And they're saying there's also false positive and false negative.
There are, because there are different genes that are in, thank you. I don't know if everybody heard her, but she had checked with their local neurologist that they see, and many physicians are still hesitant to do the genetic testing because there are actually markers on different chromosomes that are associated with Alzheimer's disease. For example, chromosome 19 and chromosome 21 are two of them I know. And 19, for example, is also associated with Down syndrome. And just as a little fact, that persons with Down syndrome, if they live long enough, 100% get Alzheimer's. So there's lots of links, so narrowing it down, like you mentioned, there's still a lot of questions and false positives, so it's not something that has really been pursued at this time or encouraged. Active exercise your body and your mind in terms of prevention. There's lots of stuff out there right now about doing Sudoku and doing puzzles and all that kind of stuff. If you just stick to that, the only thing that's going to happen is you're going to get really good at puzzles and Sudoku. So if you get solicited to buy into something like that, be cautious, because you really need the combination of the body and the brain. We all it's all one big organ. It all works together. So basically whatever is healthy for your body is also healthy for your brain. Kind of goes to the comment that you made about how people seem to be a little bit more alert and energized when they've had activity, and I think that's true across the board because it gets your body moving and your blood pressure and all those kinds of things that help keep your heart healthy and all those other body parts healthy also are very healthy for your brain. Having an active social lifestyle. That doesn't mean partying all the time, but what that does mean is having friends and interactions, so that basically what that does is it helps stimulate the brain. It helps you stimulate interactive skills and qualities, and it has that whole feeling of inclusiveness and being part of something, because we are social animals. And so being social as opposed to isolating yourself has also proven to be on the preventative side. Education and marriage. I thought you'd get a charge out of this. And I really think that ties with some of the social pieces, because as a person ages, a lot of times social activity involves coupling, it involves being in social environments with other environments. And so marriage itself overall has a positive impact on people with or without dementia. There's your prevalency information. And I thought this was really interesting because this is kind of hot off the press. In Michigan, so I put state, national, and international. In Michigan, there are 175,155 that have Alzheimer's. Now this number of 269, that includes all of the neurodegenerative diseases. And that includes the dementia with Lewy bodies, vascular dementia, Huntington's, and Parkinson's. So when you combine all these other neurodegenerative, it bumps it up to almost 270 in Michigan. Nationally, we're at 5.3. I mentioned that at the beginning. Internationally, 35.6 million. And this is kind of the scary part that I started talking about earlier. By the year 2050, the global prevalence is estimated to be at 115 million. 58% of persons with Alzheimer's disease live in developing countries, and that answers the question that you had, sir, over here. That as countries like, I don't know if you can see at the bottom there, but China, India, South Asia, and Western Pacific, these are areas right now that are undergoing a lot of industrialization, and those are the areas, those are the locations where the expected increase is expected to be the greatest of Alzheimer's disease.
Because of the environment?
I don't know. It didn't say that, but in terms of, what it didn't say is that these countries are also experiencing other health-related issues that they hadn't experienced before, like high blood pressure and high cholesterol, all those other kinds of things that go with our lifestyle, that if those things are increasing, it makes perfect sense that things like Alzheimer's disease is increasing too. Yes?
So the vaccine,
That, because that's when all of us baby boomers are going to be right about 80, 85. So we've got a bell curve of baby boomers that is hitting right now. And the population of people with memory loss is going to be consistent with the number of people. So the incidence is going to increase. Yes?
So is the disease increasing itself, or is it just the population?
Right now the indication is because the population is increasing, which still has a significant financial implication, which is where we go with this. National health care costs currently for caring someone with Alzheimer's disease or some of these other related dementias is $300 billion annually. This is a terribly expensive disease, from healthcare costs to caregiver costs to all of those other kinds of costs associated with taking care of someone with memory loss. By the time this 2050, we're looking at 20 trillion. It's a huge, huge, that's why I said geriatrics is the place to be. Individual cost currently is roughly around 57, and I actually think that's a little low. But most costs currently are being covered by family members. Caregivers, and I'm going to go into this quickly because I'm running late here. 1 out of 3 people right now currently know someone that's dealing with disease or dealing with it in your family. Most caregivers don't recognize themselves as caregivers, and that's a problem, because the incidences of caregiving is terrible on your health. 80% of caregivers suffer from depression. 60%, and this is information that just came out in the new Shriver report, the book that just came out. 60% of caregivers are women, and 60% of caregivers, not just women, but 60% of all caregivers die before the person that they're taking care of because of the stress related to caregiving, because of that 24/7 and dealing with behaviors and dealing with changes in financial and lifestyle issues. It's a huge number. It's amazing. So it's important to recognize, if you are a caregiver, some things to do to help yourself. These are just some frequently asked questions that I get. Probably one of the more popular ones is this, and this is why I put that. Why can I remember some things that happened a long time ago, but I can't remember what happened a few minutes ago? If you think of the brain as a computer, and you're entering something on your computer and the power goes out, what happens to that information on the screen? It's gone. Can you retrieve it? Nope, not so much. Brain is like that. If your brain is not able to put information into long-term memory, you can't retrieve it. So if you've got a damaged part of your brain that's not allowing you to retain information for very long, it never goes into long-term memory. You can't retrieve information that you never had stored. So that's just part of it. And I'm going to let you go because I've talked too long.
Well, I'm not going to let you go.
Okay.
I have one announcement first. Let's thank Joy. A couple of things very quickly. One is that you may or may not know, but in the psychology department, we have both social work and